just to begin with a few statistics. Number one is multiple liver mets are more often than single ones, 90% to 10%. Both liver lobes are much more often involved in metastatic liver disease, 77% than the right or the left liver lobe. And more than 50% of all liver metastases are found within the first subcapsular centimeter. And we know that multiples are much more frequent than single ones, and you can also say if you detect one, then maybe that is, or one is none, so you have probably more than one. Both liver lobes, oh, we had that already. What about grayscale ultrasound? You already heard from Helge about the value of grayscale imaging in metastatic disease or focal liver diseases. And just that when you look at cystic lesions, these may turn out to be portosystemic shunts if they appear in the periphery of the liver, number one. So you always use color to differentiate simple cysts from these shunting tumors. And cystic metastases, they may occur in ovarian cancer, sarcomas, melanomas, and carcinoid metastasis. So this is important to have in mind. So we look very careful, and especially in patients with a known malignancy for cystic lesions, especially in these cases. Applying the most sensitive imaging procedures, that is intraoperative ultrasound, 30% of all metastases are below 10 millimeters in size, and there is a pathologic anatomic study, and that reveals that for every metastasis larger than 1 centimeter, 1.6 metastases smaller than 1 centimeter in colon cancer, and up to 4 small metastases in other primary tumors, such as breast cancer, were found. But on the other side, in patients with known cancer, only 20% of focal liver lesions smaller than 15 millimeters are malignant. So we would like to characterize, of course, our focal liver lesions and to characterize metastasis. And what you see here is, well, iris setter between happy, depressed, pensive, and angry. It all looks the same, but we would try to act better. So the ABSIM guidelines show that in the portal venous and in the late phase metastasis show hypoenhancement defects, and these phases are most useful time to detect them, and in comparison most benign. Lesions take up contrast at this time and are therefore not likely to be confused with metastasis. So criteria for the differentiation of or characterization of focal liver lesions. Number one is tumor-related contrast kinetics like transit time, arrival time in the tumor and in the liver parenchyma, and the washout behavior. We can have a early or simultaneous or late enhancement of the tumor in comparison to liver parenchyma. The vessel architecture is important. Do we have a recognizable architecture like tree-like or spoken wheel or basket sign, or do we have a chaotic architecture of tumor vessels? The direction of enhancement was mentioned already. So do we have a centripetal or centrifugal filling of a tumor? The strength and the duration of enhancement is important. So we look at the overall enhancement in comparison to liver parenchyma. Is it hypo, iso, or hypoechoic? The enhancement distribution pattern we look at very carefully, because we would like to know, is it homogeneously or is it a non-homogeneous enhancement of the tumor? And then we may also see something that we call peritumoral enhancement, and I will come to that point later. So what means hypo, iso, or hyper-enhancing? So contrast-enhanced ultrasound shows the tumor vascularity as well as contrast kinetics and enhancement level during the arterial phase. So the wash-in of contrast bubbles can be described as the arrival time of bubbles in a lesion, so before liver tissue, at the same time, or after the enhancement of liver tissue. And important to look at the intensity level. Is it higher than the level of the liver tissue, or same level or lower level? So this is how we define here in our lab hypervascularity. It means that the tumor enhancement is ahead of liver tissue enhancement, and that we have a high level of enhancement compared to liver. Hypovascularity means enhancement at the time or after enhancement of the liver tissue, and it has a lower level of enhancement at any time during the arterial phase. So this is a malignant melanoma staging examination, and you see now an early arterial iso enhancement and a washout after a few seconds. In the center we have a necrosis, but the tumor, the viable tumor tissue is iso enhancing during the early arterial phase and is then very quickly washing out. And Another example is metastasis of a carcinoid tumor in the colon, and you can see here the metastasis, you can see the supplying artery, you can see an early enhancement prior to the enhancement of the liver tissue, and it's strongly being enhanced. And again, if you look at the late arterial phase, it is already clearly washing out. So here you have a very high vascularity, and you can also see that around the tumor there you have a sucking of blood maybe, and that is the reason why the liver tissue around the tumor is hyper-enhancing. This is a liver met detected at the time of the diagnosis, so having in mind the talk of the pathologist, this is a case of a very young lady, 35 years old. All lymph nodes were free, so 1 week after making the diagnosis of breast cancer, we detected during the... And again, you can see now the wash-in. You see the arteries, you see the filling of the tumor, and the portal venous filling 3 seconds after the arterial filling. And you can see now we have 19 seconds after injection, 21 seconds washing out now at 23 seconds at a very, very early stage. So we would say this is a hyper, and this is the late phase, and you see it's clearly washed out. Malignant melanoma, be very, very careful when you look at patients with malignant melanoma, because metastasis in the liver very often look rather cystic. So I show you different transducers and the same lesion. So this is cyst maybe, so with other technique also looks like a cyst, maybe from different projections. This is a high-frequency probe because we love to use high-frequency probes for the superficial liver tissue. And again, we would say, well, this is probably a cyst, but you can see it's not really perfectly round-shaped. So this is the reason why we changed the transducer again and started with a contrast examination. This is the cyst, and now you can see the contrast is coming and it's filling. Number one, number two, and you can see a third metastasis that we couldn't detect before, and this is 2 millimeter in size or 2 millimeter by 4 millimeter size, and it's also washing out. So all three are washing out. You can see here it's washed out, and you can see also the supplying artery of this very tiny subcapsular metastasis. So this is for us state of the art in order to really find out all these tiny subcapsular metastases. Of course, we cannot reach all parts of the liver to do this kind of examination, but in this case, it helped us a lot. So characterization criteria in the arterial phase is the arrival time between tumor and liver. I already mentioned that. So which tumors are typically hypervascularized and which ones are hypovascularized? Islet cell tumors like insulinoma, gastrinoma, neuroendocrine tumors, carcinoid, sarcomas, very often RCC, thyroid cancer, malignant melanoma, ovarian cancer, breast carcinoma, and also lymphomas, I'll show you later. And then we have, CCC is of course not a metastasis, I'm sorry for that, but adenocarcinomas from the GE tract, lungs, pancreatic cancer, squamous cell carcinomas, and sometimes also malignant melanomas. And you can see, you find both here. You find breast cancer on the left and on the right side. Some people think it has something to do with the receptor status of the patient with breast cancer. So in the receptor negative patients, you have less vascularity in the primary tumor and the metastasis than in those with positive receptor status. This is also a patient with a malignant melanoma. S100 was very high, and you can see here a thrombosis of the portal venous branches. And again, this is a high-frequency probe, and you can see the thrombus here, and you can see that the thrombus is thrombosed. During the arterial phase, you see a take-up of contrast. This was the only site of metastasis, so this patient had all imaging modalities, but this was the only location for metastasis, so we biopsied this tumor. This is the staining. This is a CD34 staining. We love to do that because then we can prove this is a staining for the endothelial cells of the vessels. So all these red spots here mark the vessels. This is a patient with multiple liver masses, fever, and a recurrence of a urothelial carcinoma. And these are two of multiple lesions in the liver. And in grayscale, you can already see here are still some periportal. When you give contrast agent, the arterial phase does not delineate the tumor, so it's a homogeneous enhancement during the arterial phase. You can see the vessels running through the tumor, so no alteration of the vessels. But then at the end of the arterial phase, you can see a washout and clearly see still veins running through. Okay, and from this behavior, you can say this is a non-Hodgkin lymphoma, because non-Hodgkin lymphomas respect the vessel, the course of the vessels. So this is rather typical behavior. We also have some of the non-Hodgkin lymphomas and then we have a phenomenon that we named peritumoral enhancement. So peritumoral enhancement may occur as an artifact. So you have then a posterior hyperenhancement like in CEUS, or posterior hypoenhancement due to a very high bubble concentration in the tumor. So this attenuates the enhancement, or attenuates the sound waves. And then you have segmental hypoenhancement behind the tumor because of vessel occlusions maybe, or a stealing effect due to shunting. And you may also have a circular peritumoral enhancement, and I will show you examples of all these. So this was a patient where we were looking at or looking for tumor. We see here 2 metastases in the right liver lobe, segment 8, and then we were very astonished because we saw, when we again did the contrast examination, this is the second shot, and in the second shot, look at the arterial phase, what is happening. Here are the tumors, and you see part of a segment 5 is not enhancing during the arterial phase. It's completely spared. This is the gallbladder here, but this part is not enhanced. And this is the portal venous phase. It is again completely enhanced. So there's only an enhancement that starts during the portal venous phase, and we thought, or we interpreted it as an occlusion of the hepatic artery in this subsegment. Patient with a colon cancer, this is a tumor in segment 5, and you can see it here, the intraoperative image of the same tumor. And what color Doppler does not really tell you something in most cases, but we use color Doppler to see from where do the feeding vessels come from, so to optimize this. And this is a CEUS examination, and we think what you now see is arterial portal shunting. Contrast is coming, tumor is filling, and at the same time that the tumor is filling, you see a posterior to the tumor, towards the capsula, you can see a hyperenhancement of normal liver. If you look at the same patient a little bit later, then you can see a washout, and what you can still see is a hyperenhancement here around. Another example, urothelial carcinoma, you can see the tumor here, and you can see that the tissue around it is hyperenhanced. And if you wait a couple of seconds, then you can see the washout phenomenon of the tumor. So the colon cancer, again, a similar case. You can see here the filling of the tumor, and at the same time, with the arrival of the contrast bubbles in the arteries, you can see the segmental enhancement. And if you analyze this loop and go to still frames, back to still frames, this is the frame 15 seconds. This is the tumor, this is the peritumoral enhancement or segmental enhancement behind it. 4 seconds later, you can see the filling of the portal vein. 22 seconds, you can see the 2 vessels here, and in the early portal venous phase, the start of the washout. So we think this is all linked to shunting between the hepatic artery and portal vein, and hepatic artery and liver veins. Another patient here with a neuroendocrine metastasis, and just look very carefully what is happening in the arterial phase. So the tumor is filling, you see the arteries, and then the tumor is growing, becomes bigger, and after a while it's being washed out. Now we have an ISO enhancement now. We don't see this. Again, I show you the times. So this is 10 seconds after enhancement. You can see the early arterial phase and the filling of the tumor. You can see the supplying arteries. 18 seconds post-injection, you can see here the portal venous branches. You can see that the tumor is growing and very well defined. And this is the drainage, venous drainage. This is an image 32 seconds after injection. Do we really need this kind of information? I think yes, it may help, and this is a bit spectacular, but I think it is of value. So this is a metastasis from a malignant melanoma, and you can see the hyperenhancement. And if you wait a couple of seconds, then you will see that the tumor is much smaller. So the washout size of the tumor is much smaller than the arterial enhancement of a well-defined tumor. And if you treat this patient with chemotherapy, and now it starts to get interesting, then this peritumoral enhancement disappears. So this patient also had CT, and on CT they said there is no change between the first or the CT scans prior to chemotherapy and 6 because when you compare both, and we did that here, you see that the hyper-enhanced area around the tumor is 2.8 centimeters, the washout side is 2 centimeters, and 6 weeks after we saw the tumor as 1.9 centimeters, so it's the same size, and this is exactly what the CT told us. There's no change between the two, but what we saw was a decrease of the peritumoral enhancement, and in the following weeks the tumor then began to shrink, and after 3 months the tumor was very, very tiny, only 3 to 4 millimeters. So we think that maybe this is the beginning of a response to chemotherapy. Okay, so that was my contribution to the liver metastasis, and I thank you very much for your attention.